Well, thank you so much, Bert, for the invitation. And it's great to see many familiar faces here. So it's great to be with you. So let me share my screen and go into full screen mode. Okay, so Bert is correct that much of my research does focus on censored and truncated data. This happens to not. This happens to be my other continuing interest, which is in clinical trials, trial design, sequential monitoring. So this is a long-time interest of mine, going back actually to my PhD dissertation. And I've never left it because I do find clinical trials to be extremely interesting. So anyway, that's what this is about. So I'm going to be talking about N-of-1 studies. And this arose from a collaboration that I had at Harvard at Mass General with Dr. Stephen Arnold. He's a neurologist, specializes in Alzheimer's disease and other neurological diseases. And it's also work that I did with Xu Jiang, who was a postdoc of mine at Harvard and now is at Washington University. Okay, so here's the plan. I'll begin just by reminding everybody about the major principles of the randomized controlled trial. And then I'll talk about the N-of-1 trial. Many people react to that by saying, how could you possibly have a trial with an N-of-1? And so we'll talk about that. I'll talk about its place in Alzheimer's disease research. And then the gist of my contribution here in my research is about extending this design to the sequential framework, which is something that I always think about because that was really my first work in clinical trials, had to do with sequential design, meaning allowing for interim analyses and early stopping for the purposes of efficiency and ethics and other reasons. So I'll talk about some of the details of what that means for the design of the N-of-1 trial and the analysis. And then I'll give an example of a study that was actually conducted at Mass General, methylphenidate. So as a demonstration that this could be done. Okay. All right, so the randomized controlled trial, as you all know, is the most common study design for regulatory approval for common diseases. It, of course, provides a good estimate of a drug's effect in the average patient. However, there are some limitations, and one is its relevance to real-world patients is always of concern, or at least always something that should be considered, just because of how these randomized controlled trials are constrained with in terms of their eligibility criteria and in terms of their limitation of heterogeneity across patients. So here's one statistic or two statistics from a paper that I found in 2005, which said that the average randomized controlled trial may exclude 75% of potential participants who have the disease or disorder of interest, and ultimately may enroll only 10% of all candidates with this disease of interest. So it is limited with respect to the entire disease population. And for good reason, of course. So exclusions are intended to reduce the variability of the outcome because, of course, in a very expensive trial, everybody wants a finding. And so, of course, to do that, we want to reduce the noise and variability. And so they often will exclude common comorbidities, concurrent medications, disease that's too mild, disease that's too severe. And this is common in Alzheimer's disease trials as well. Now, the problem, of course, is if it's, and sorry for the typo here, but the external validity is is questionable if a large percentage of the patient population is not enrolled. And another problem is that maybe a drug is effective in a particular subgroup of patients that happened to be a group that was excluded. You wouldn't know that. Sample sizes need to be very large, even with exclusions, when the treatment effect is modest. And the other problem with clinical trials is that they can be slow, and enrollment may be very challenging when they are so selective. So an answer to that, or a response to that, or an alternative to that, is the N of 1 trial. So what is the N of 1 trial? Well, in its simplest form, the N of 1 trial is just the general practice of medicine. So it's just a single patient. It's prescribing a medication, observing a response within that patient, switching medication if necessary, switching again, looking at response. So that's just the natural course of treatment and medicine. Back in the 1950s, this single patient trial, which it could be called, was formulated in a more rigorous fashion. And so this was defined as an experimental clinical design to determine the effect of an intervention in a single study participant. And the way it works, and I'll go into more detail, is that the participants undergo several blocks of crossovers between the experimental treatment and the control or the comparator condition. And then the relative response in each block is measured and then accumulated over those multiple blocks. And so what does it mean to conduct it with rigor? Well, this would have to be done, and this is the only hope of obtaining an unbiased estimate of the effect for the single participant, which some authors have described as being on par with a systematic review of conventional randomized controlled trials. And so what is rigorous is that treatments and doses would be pre-specified, not just arbitrarily selected as time goes on. They would be given for pre-specified durations of time, so maybe 2 weeks of this, 2 weeks of that. There would be placebo washout periods if necessary, if there's carryover effects. Blinding, of course, would be very important, double blinding, in fact. There would be repeated blocks, so not just a single crossover, but a multi-crossover, multiple crossovers. The idea being to attenuate effects of systematic and random error. And then there would be randomized sequences of treatments in each block. So if there are 2 treatments, patients would be randomized within a block as to whether they receive A first or B first. But then furthermore, the whole sequence may be, needs some consideration. So here I've given 2 examples. The second one, AB, 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 probably is not preferable and might be excluded from a 2-treatment trial, because you wouldn't always want A preceding B in case there are carryover effects or other kinds of effects. So you would want to mix them up, as in the first example. The part of the rigor would be systematically applied outcome measures. So this is a good list. And as I mentioned earlier, these are also referred to sometimes as multi-crossover trials. So, everyone is familiar with the crossover trial, which typically means a single crossover. This is a multi-crossover design. Not every drug and not every disease or disorder is appropriate for this kind of a trial. So typically this design would be considered for drugs that provide symptomatic relief in a chronic condition rather than a strongly progressive condition. And the drug should have a rapid onset of action with a short half-life, so that, again, there isn't much carryover and so that effects of the different drugs can be observed within a reasonable time frame for a trial. And then likewise, there should be quick cessation of biological activity of the drug after withdrawal to avoid carryover effects. And of course, as in the single crossover design, these could be handled analytically, but then we have to make assumptions and it can get messy. So there is a large literature on multiple N of 1 trials, but that's not what I'm talking about, but I'll just mention it here. So when people refer, and when you look in the literature for multiple N of 1 trials, that is referring to methods for combining across patients using meta-analysis or Bayesian methods. And that's perfectly valid, and that is fine. And of course, doing this may provide increased power over the conventional randomized controlled trial, because the subjects are serving as their own controls within the single N of 1 trials, which are then combined. So of course, that means there's a lot of control for confounders, for comorbidities, whatever they may be. And this way of combination leads to a population level effect. Okay. So here is a schematic just to describe in a picture what I have described in words. This came from a paper that I co-authored with Stephen Arnold, whom I mentioned earlier. This was in Annals of Neurology in 2018. And here it just shows the design where there would be screening for eligibility. There would be some assessment of the outcome. There would be randomization to one of 8 possible treatment sequences. And it's 8 given that we are selecting a design with 3 cycles or 3 blocks and 2 treatments. So here are the 8 possible sequences, given that we want to have each treatment within each block. So A, B within each block. Again, I put asterisks on these 2 bracketing designs, because these are ones that would typically be excluded because they're more systematic in their ordering of A, B, and BA. And so anyway, here's how the trial goes. Outcomes are measured along the way, and then the results are combined. Okay, so in Alzheimer's disease, so Stephen Arnold is an Alzheimer's researcher. He was very interested in this in Alzheimer's disease, mainly because he thought that there was a place for it, not for all kinds of drugs, but for symptomatic drugs in short time frames to quickly find something that could be effective. So within Alzheimer's disease, he did a comprehensive review of clinicaltrials.gov and the literature. There are certainly single crossover trials. There are very few multi-crossover trials that have been conducted, fewer than a handful. Now, again, people may argue that Alzheimer's is a progressive disease. Well, that's not up for argument, that's true, but that would be a reason why it would not be an appropriate setting for this N of 1 design. However, it is also a slowly progressing disease for most people. And so it actually could be an appropriate condition for these multi-crossover trials to evaluate symptomatic treatments within a short time frame. So for about maybe a year or less than a year. Alzheimer's disease would not be suitable for disease modification effects. That would require longer trials and would be more complicated by progression and nonlinear progression. So that's not what we are considering here. So here is the design of the pilot study that Stephen Arnold conducted. This was of methylphenidate, MPH. We wrote a paper just describing the design in 2020. We had planned on 10 participants. It turned out that we only had 7. This was during COVID. It was difficult. But anyway, we had 7 participants. The primary outcome was simply feasibility, given that there was this multi-crossover aspect, which is certainly a more complicated design than a parallel group randomized trial. The secondary outcomes, which were actually of more interest to us, thinking of a potential future trial, and those were neuropsychological assessments and daily brain games. So the major neuropsych assessment goes by the name of RBANS. I forget what that stands for. And Lumosity is the name or the company name of the, I think, iPad-based daily brain game that the patients underwent or that they took. And so MPH, methylphenidate, is a psychostimulant drug approved for the treatment of ADHD and has been suggested for general memory and attentional cognitive enhancement. So symptomatic relief for somebody with mild cognitive impairment or early Alzheimer's disease. It's a safe drug and patients tolerate it. So for all of those reasons, it seemed like a good option, at least for a pilot study, and potentially as a good symptomatic treatment. Okay, and so within this pilot study, we, as you'll see when I show you the schematic on the next page, we randomized the treatment order and it was completely blinded. And so here's what it is, and you can just see that we had 3 blocks. Sometimes I call these cycles. I'm using them interchangeably. And each one lasted for 2 weeks. And each patient was, again, randomized to whether they received MPH within part A of the block or whether they received placebo within part A of the block. And then they received the other one in part B of the block. And again, as I mentioned, we had planned on 10 patients. Okay, so that's the background. So now shifting gears to the sequential framework. So as I mentioned, that's sort of my first love in statistics was sequential design of clinical trials. And so I do think about that, and of course I'm very familiar with that framework. So it was very natural to me to think about how could we apply the sequential framework to this N of 1 framework? And the idea is to have a stopping rule for each individual, which would allow us to stop the trial, stop the N of 1 trial, as soon as something is, some result is identified for that individual. It could be superiority of A over B, it could be superiority of B over A, or it could be equivalence of the two. And I wanted to acknowledge that any of those 3 possibilities could be the case. There can be heterogeneity across patients, especially in a symptomatic treatment. Maybe A works better for me, but B works better for you, and maybe for somebody else, they work in the same way. Or maybe they're not effective, and we'll bring that in as well. So now, back for this MPH study, I only had 3 blocks, so stopping early wouldn't be such a big deal because, maybe you would stop at block 2 instead of block 3. It's probably not worth all of that extra effort and machinery in the design. However, as you'll see when I show you some potential designs, there could be examples where you might calculate that you need 10 blocks. Well, that's a lot of blocks, and that would be a case in which the sequential stopping could be quite useful. And so that was for each individual. But then the additional idea that I wanted to implement here was to have another stopping rule at a higher level for the study as a whole. And so the idea for that would be, while I'm having these individual stopping rules go on for the individuals in the study, I would have an overall stopping rule for the study, which would allow me to stop the study as soon as superiority or equivalence is identified at the population level. And of course, that needs to be defined. What does that mean? Does that mean that more than half of the patients do better on A than B, or does it mean more than 75% of the patients do better on A than B? And of course, that's all context specific, how that would be defined. Now, that raises interesting questions itself, because, what do you then do if you stop the study, but you still have individuals on the study? So do you continue with them and let them find their own personalized best treatment? So that's one question. And then I guess the other question is, if there is heterogeneity among patients that is discovered, even if 75% of the patients for whom, even if let's say A is better than B for 75% of the patients, would you then just prescribe A to all patients, or how would you deal with the fact that you now know that there's this heterogeneity in response, even if it's overwhelming evidence for one versus another? Okay, so now the details, and I won't spend too much time on this notation or anything, but just to give you a sense of what is behind all of it. So the typical way in the N of 1 literature, and much of this has been published by Steven Sen, for example, is simply a mixed effects model. So if there's a continuous outcome, so here I've written it as if we have a continuous outcome Y, for individual I in block J and occasion R. So occasion is often the term that's used to mean, is it the first part of the block or the second part of the block, A or B? And so, here's the model. So it's what you might expect. There's a random effect for individual I. There's a random effect for individual I in cycle J or block J. The important piece, or the more interesting piece, I think, is the treatment effect. And so the way that we're dealing with the treatment effect here, so that's tau. So let me start with capital T, actually. So the idea is that there's heterogeneity across patients, and we accept that. Again, maybe mainly because this is more of a symptomatic kind of treatment, at least with respect to Alzheimer's disease. So there's heterogeneity of the treatment. So that's captured in this multinomial. Each patient has their own outcome, which follows a multinomial distribution, meaning with one probability, A is greater than B, with another probability, they're equivalent, with another probability, B is better than A. So for each patient, they're in one of those three groups. But then we assume that there's error around those means, those treatment effect means, and that's the psi term in this tau. Okay, so anyway, the idea being, the main idea again is that there's heterogeneity across patients in terms of their response to treatment, and we build that in and we allow for that. Okay, now for the simple analysis, we can just simply construct paired differences within each block, and ultimately get down to a very simple model, and that's what I have at the bottom of this page. So for a single individual, I've gotten rid of my subscript I, because now I'm just considering this single individual, the true N of 1 trial. And so all I have is the subscript for block, and that's J, and a constant treatment effect and an error term. And of course, all of this can be, we can layer a lot back on this, allow more correlation, but this is the simple framework. And so then for interim analyses, what we assume is that we will conduct a maximum of capital K interim analyses for an individual. And that's the usual setup within a sequential design. You never want to have an unlimited number of analyses. You don't want to go on, infinitely long. And these interim analyses could be conducted after each block, or they could be conducted after groups of blocks. Either way could work. And then what I do is I just simply calculate the mean difference between the two treatments for that patient. through the small kth interim analysis. So this is little k. So that's what this D bar K term is. So this is accumulating evidence because K is increasing. K, again, is indexing the interim analysis. And then what I'll do is I'll conduct a confidence interval for the treatment effect of interest at the kth interim analysis, adjusting properly for the fact that I am conducting multiple interim analyses. It's a multiple testing problem. That's what sequential analysis is all about. And so I need to make that adjustment. So while these represent the upper and lower limits of a confidence interval, this critical value, Z, is not the typical nominal 1.96 or standard normal limit, but has to be obtained from an adjusted stopping boundary. And one of the most popular boundaries that's used in practice is O'Brien-Fleming. Of course, any one, Pocock or any others could be used. I also need to define what I call capital delta, which is the clinically relevant difference between the treatments. So that just means the minimum absolute difference in the treatment, in the outcome between treatment A and treatment B that would be meaningful. And then what I want to do is I want to stop the trial for an individual as soon as there is compelling evidence of any of the following. So either superiority of A, or equivalence of A and B, or superiority of B. And those translate in the following ways that I have listed here with respect to this treatment difference delta. In addition to this, I want to allow for early stopping for futility. So what that means is as soon as there's, well, if at any interim analysis, there is a sufficiently small probability of a finding of superiority or equivalence by the end of the trial at the capital case analysis, then I'm going to stop early and just declare this study has no hope and I'm not going to find anything. I'm going to stop. I'm not going to subject the patient to more evaluation and more treatment, and we'll move on to something else. Okay, so here's the stopping rule just written out. And you can see how it works. Here I have my confidence interval at the kth interim analysis, and the rule goes as follows. So if this interval lies within minus delta to delta, I will declare equivalence of A and B and stop. So that patient is done. A and B are the same. I choose the one, the choice of which one to use becomes a non-statistical choice. It's which one is less expensive, which one has less side effects, whatever it might be. Now, if that's not the case, I would alternatively stop if the lower limit is greater than delta. And if that's the case, I would declare superiority of B over A. Stop, give the patient B. If that's not the case, then I would look to see is the upper limit less than negative delta. If that's the case, I declare superiority of A over B. I stop, I give the patient A. And then here I have my futility criteria, which you can see are conditional probabilities of the results at the end of the trial. So that's at capital K, given conditional on the results at the interim analysis little k. And so basically what I'm looking at are probabilities of findings of superiority or equivalence at the end of the trial, given the current data. And if those are all small, like perhaps a threshold of 20%, it could be 10%, whatever you might choose. If those are small, then I'm just going to stop because I don't believe that by continuing, I'm going to suddenly get much higher than 20% chance. Oops. And if none of those are met, then I just simply continue. I go on to my next interim analysis. And finally, if I've hit my truncation point, meaning I've gotten to capital K interim analyses, I stop and I declare the trial inconclusive. So we just have not found we don't have a finding for that patient, which is a possibility. Okay. All right, so now once I have this set up, I can figure out how to design this trial. And I do it the way that we always design a trial, through specification of the operating characteristics that are of interest. So of course, the type 1 error. So here I've written it down. I won't go through all of this, but what I can show is that the type 1 error, although it's more complicated in this context, simply translates into a one-sided stopping boundary with that specified type 1 error and a null hypothesis mean of 0. So a very simple design. And I can obtain these. This is just a side point. Of course, there's software for obtaining these critical values. There are packages, proprietary packages that you can pay a lot of money for, or you can use packages in R that, of course, are free, like LD bounds is one of them. Now, in terms of power, again, I can write down power. So power would be the probability at the end of the trial that the lower limit is greater than delta, or the upper limit is less than negative delta. So by power, I mean finding superiority either of A over B or of B over A. Either one of those counts. And I can then see, well, that translates also into a two-group, one-sided level alpha 1 test with an alternative of tau minus delta. So anyway, this tells me how I can use, so the basic takeaway from here is that I can use standard software for designing sequential trials. As long as I know how to set things up properly, I can use that to design this N of 1 trial, which again is slightly different. And then here I have power for the equivalence outcome, which again translates into a standard calculation, but now the power has to be adjusted. So if I want 80% power to detect equivalence, it turns out I need to choose the design or the number of cycles relevant for a 90% trial. So that's what this mapping shows me. Okay, so moving on. So thinking back to our methylphenidate study, so I looked at the R-bands index. So remember, that was the neuropsychological outcome. This is from another paper, which I have referenced here. And so this paper, which used this index in a similar population, so it was comparing healthy controls to individuals with mild cognitive impairment. This gave me the standard deviation that I needed. It also gave me a reasonable estimate for this equivalence parameter delta, and it also gave me a reasonable guess at an effect size. And so here I calculated the number of cycles that would be required for an N of 1 study, so for the different R-bands indices. And so you can see, for example, that the immediate memory index could be completely inappropriate, unsuitable for the N of 1 study, because I need 232 cycles, so that I can't do. However, the total scale, or maybe even the delayed memory, are much more reasonable in terms of requiring fewer cycles. And so here's a simulation study that I conducted based on this design. What you can see is so let me give you the lay of the land here. So N is 10. That means a maximum, this is the capital, same as the capital K I was referring to, maximum number of cycles that I would consider is 10. The top half of the trial of the page are the results when there is no futility design. The bottom half of the page is when I have a futility design and my probability cutoff is 20%. And you can see that, and then here I have listed the values of tau. These all are positive, and so they all correspond to the scenario treatment B better than treatment A. And you can see that I have verified my design specification, because indeed I am getting 80% power, as I should, when I have up to 10 cycles, and when B is superior to A. I find that about 18% of individuals end up with inconclusive outcomes. But what's interesting and nice to see here is that the expected number of cycles is 6.4. So while the maximum is 10, I see that on average, I only need 6.4 cycles for any given individual. So that's a reasonable saving. So that's useful. In the presence of futility, not surprisingly, we have a smaller expected number of cycles. And that's not surprising, because when we have the futility bound included, we're stopping early even more frequently. However, we have a smaller power, 71%, for detecting superiority, because sometimes we are making a mistake and stopping for futility when in fact we have superiority. Okay, and I have a few minutes left. So now I want to go on to the next level. So remember, I have two stopping rules, one at the individual level, and that's what I've really talked about so far in terms of the design and the results. And now I want to move to the multi-N of 1 trial as I view it, which is not meta-analysis and not Bayesian combination, but it is just analyzing multiple individuals together. And so now, once I have multiple individuals, I need to go back to my multinomial assumption on the treatment effect. And that's where it makes sense. And that's where I bring in the heterogeneity. And so recall here, I am assuming that the patients can have one of three outcomes: equivalence or either of the two superiority outcomes with these probabilities, P1, P2, P3. So what I want to do now is set up another hypothesis test, now not with respect to the tau, which is what I had for the individual, but now with respect to these P's, these probabilities, because I want to know at the population level, I want to know something about P1, P2, and P3. Now, there can be many things that I might want to know. So there are many possible hypotheses that I would set up regarding these probabilities. But as an example, one of them might be, I'm interested in superiority of B versus A. So that would translate into a test of P3. So I want to know, is P3 larger than some P0, whatever that P0 is. So maybe P0 is, 1/3, 33%. Maybe I want to know, is B better than A in more than 1/3 of the population? Or maybe I want to know, is B better than A in more than half of the population? So this, again, is one example of a test I might want to conduct. And so now what I do is I have to aggregate the results from the individuals and then use those in my test of these multinomial proportions. The difficulty here is that I can only use individuals who are conclusive in their individual N of 1 trial. So that's not everybody. So I have some selection bias going on. And what that means is that the estimated P3 among those conclusive individuals is not the same as the P3 in the population. And so I need to somehow adjust for that. And then likewise, a P0 at the population level is not the same thing within, within the selected population. So, so this is a little complicated addition here that has to be done to translate into the selected population in order to do the test on the right parameters that then translate back into what is of interest at the population level. So that is what I'm talking about here. And then once I have that, then I simply need to design, as I mentioned, a sequential study of this multinomial proportion. Here I have the very simplest sequential study that could be designed. And I know I can do better than this. And so this is just simply a fixed sample design of test of proportions, where my rule is to stop the trial as soon as a certain number of individuals have the conclusion that B is greater than A. And the reason why this is sequential is that I can be looking at the data as it accumulates and stop as soon as I hit that threshold for the number of individuals with B greater than A. But again, there are other designs that would likely be even more efficient. This is a hard slide to read, but I will just point out, so this is the same design that I showed you for the N of 1 trial, now accumulating, now aggregating several individuals. So the M here is the total number of individuals. And then again, what's of interest is to compare this M to the expected number of individuals under this sequential stopping. And again, you see that there is savings here. So for example, in this third case where we calculate we need to have 19, it turns out that on average, we only need 12.9 in order to make a decision about the population. So here's just a demonstration. There's a lot more in here. I won't go through these details. Just a demonstration that there is savings to be had at the group level as well as at the individual level. Okay, so that was that is the design in a nutshell. It's pretty conceptual at this point. There are a lot of details to work out, and it's I think the biggest takeaway is that it's not appropriate in every setting for every drug. But there may be some in which it is, and in which it could be very useful. And it certainly can hasten findings for individuals, and it also can potentially hasten the findings for a population. Again, there are complexities, there are details. One that I haven't mentioned yet is the second to last point, which is a lot of this depends on the flow of the individuals through the study. So this doesn't work very well if everybody enters the study at the same time. Then there isn't going to be any savings to be had. But if there's staggered entry, like there often is in real trials, then it could potentially be useful. Okay, I will stop there. Thank you.